Hi everyone, and welcome to today's webinar titled Treatable Traits for Long COVID. The Centre of Excellence in Treatable Traits is really excited to be able to bring this webinar to you. We've got three outstanding speakers, and after each presentation, each speaker will give their presentation, and at the conclusion of the three presentations, we'll then have a Q&A session. This is a really important topic, and what we're basing this webinar around is an important paper that looked at how long COVID could be addressed using the treatable traits concept. So it's a nice bringing together of a really important clinical problem, which is long COVID, and an innovative solution to complex health issues, which is treatable traits. So it's going to be great to hear what our speakers present to us and also the Q&A that we have at the end. I'd like to start with the acknowledgement of country. And today we're hosting this webinar on the traditional lands of the Pambalong clan of the Awabakal people. And I'd like to pay my respects to the elders past, present and emerging, and recognise the traditional custodians of the lands where you are and where you're joining this webinar from. So just to say a few things about housekeeping, the webinar is being recorded and it will be available on the CRE website at a later date. And as I said earlier, we have the three presentations. They'll go one after the other, and then we'll have questions at the end. And you can type your question in the chat, and we have a moderator who will highlight those questions as they come through. So let me introduce the first speaker, Hayley Luthwaite. So Hayley's addressing the topic long COVID treatable traits. And Hayley's an accredited exercise physiologist and postdoctoral researcher with the NHMRC Centre of Research Excellence in Treatable Traits. She was also the senior author of the ESSA guidelines document titled Safe Exercise Across the Clinical Course of COVID-19 in Adults. So Hayley, welcome, and tell us about long COVID and treatable traits.
Thank you, Peter. So as Peter said, I'm going to be presenting mostly the paper that we published at the end of last year on treatable traits for long COVID, and the authors of this paper are on the screen and also the presenters today. So this is the paper that we published here in Respirology. You can access it scanning the QR code. And then the figure on the right just shows that the paper did actually get some attention on social media mostly, and this attention was mostly from members of the public. So the whole basis for this paper was looking at treatable traits as a model of care. Many of you will be familiar with treatable traits as a model of care, but if you're not, just briefly, treatable traits has been developed as a model of care to help manage complex and heterogeneous chronic conditions. So it's been mostly applied in severe asthma, but also people with COPD. And so this model of care, the basis for it is providing a multidimensional assessment. So it deconstructs the disease into its traits or the problems that have been identified. And then the management is tailored according to what traits are present. So then the first question really is, does this model of care apply to long COVID? And if it does apply, then that means that long COVID is complex and heterogeneous. So this definition on the slide here is the WHO definition for long COVID, and you can already see how long it is that it likely is going to be a complex condition. And so breaking down that definition, someone has said to have long COVID or post-COVID-19 condition if they've had a history of SARS-CoV-2 infection at least 3 months prior. The symptoms last for at least 2 months. And there can be a range of different symptoms, and these symptoms may relapse and remit over time, and that they have an impact on the person's daily function. So you can see really that we know that long COVID is complex and heterogeneous, so it's likely to fit into this treatable traits model of care. But what we don't know really yet is how to treat long COVID. So then this paper, the first research question, first just wanted to look at what are the most prevalent long COVID-19 treatable traits. So what are those problems or symptoms that occur with long COVID that we can then direct that personalized management strategy toward? So every time I do a presentation on long COVID, I look at long COVID on PubMed and see how many hits there are. And every time I'm surprised and overwhelmed by how much research has been done on this topic. So just the other day when I did this, from 2020, there's been over 30,000 studies focused on long COVID. So to try and consolidate this evidence, we did an umbrella review or a review of reviews. So when we did this review, we were looking at any systematic review that had a meta-analysis that reported on the prevalence of long COVID symptoms and really applying that WHO definition to long COVID, that it had to be at least 3 months from the initial confirmed COVID-19. And we only looked at studies that were published in English. So the search identified 23 systematic reviews, which is a lot of systematic reviews considering the short timeline of long COVID. There were more reviews identified, but the definition for long COVID wasn't following this WHO definition of at least 3 months. So an important part about the umbrella review of reviews is really looking at all the primary studies that have been included. So across those 23 systematic reviews, there were nearly 600 primary studies that had looked at the prevalence of long COVID symptoms. So then to really decide, do I review all of these reviews, or is there one really principal or primary recent review that's included most of those studies? I did a citation matrix, and part of that citation matrix is calculating, the degree of overlap with this corrected covered area. But really there was only 5% overlap across all of those reviews for the primary studies included. So this is considered slight, which means I summarize all of the evidence from across all of those systematic reviews. And what this really means is that there's been a lot of reviews and they all have such varied eligibility criteria that they're all kind of looking at a different part of long COVID. So what I was interested in were any primary studies, or what were all those primary studies that were included in each of the systematic reviews? What was the total number of symptoms that were reported in each of those reviews? But most importantly, what were the 10 most prevalent symptoms reported? So I extracted data on the symptoms name verbatim, and then the pooled prevalence for those symptoms. And so what I found that in the 10 most prevalent symptoms or complications reported, there were 34 unique symptoms. And together we clustered those into 8 different clusters. And so here they are, the clusters. So we found neurological symptoms were common, chest, psychological, pain, fatigue, sleep impairment, functional impairment, and then some other symptoms that we grouped as other. Unsurprisingly, fatigue was the symptom with the highest prevalence in 11 of those systematic reviews. The other systematic reviews where fatigue wasn't the most prevalent symptom, this is mostly because they had a specific focus, so they weren't looking at fatigue as a symptom of long COVID. So for example, we had 2 systematic reviews that only looked at the prevalence of cardiac complications and symptoms. So really fatigue is the number one, and neurological were the most common long COVID symptoms or complications. So not surprisingly, long COVID is complex and heterogeneous. So this figure here just shows the how common different symptoms or groups are when we grouped them into those 8 clusters, and that you can see that neurological and chest were the most common symptom clusters. So now that we've looked at what are the most common treatable traits in long COVID, the second part of this paper was looking at, well, what evidence is there available for how to either prevent or manage long COVID? So we had this second systematic review in the paper looking at both pharmacological and non-pharmacological therapies for long COVID prevention or management. So for this second systematic review, papers were eligible if they were an RCT that explored any intervention for either the prevention or management of long COVID. So studies looking at the prevention of long COVID, they had to include participants that had confirmed acute COVID. An intervention had to be delivered during that acute COVID-19 phase and could be compared to any other comparator. And the outcome was incidence of long COVID at 3 months post the acute infection. So the intervention was delivered while they were mostly in hospital with COVID, and then they had to be followed up for at least 3 or more months. The other part of the review was looking at any interventions for the management of long COVID. So participants in these studies had to have long COVID, and that could be a long COVID diagnosis or ongoing symptoms of complications at 3 months post acute COVID. And we looked at any intervention versus any comparator, and the outcomes could relate to any of those long COVID symptoms or complications, whether they were objective measures of physiology or function or subjective reports of ongoing symptoms or impaired quality of life. So from the second systematic review, there were 18 studies that looked at interventions for either long COVID prevention or management. Only 4 of those were those prevention studies. So we had 4 RCTs. One was looking at convalescent plasma therapy versus standard care, and the other 3 were different pharmacological interventions versus placebo or standard care. And then the remaining 14 interventions looked at the management of long COVID. So 2 of these were pharmacological studies and 12 were non-pharmacological studies. So you can see the breakdown of what traits these studies looked at. We had 4 that looked at neurological traits, 2 for chest, 2 targeted fatigue, but most of these RCTs looked at the functional impairment treatable traits. So the evidence on the neurological traits, there was those 4 studies. 2 of the studies actually reported data from the same participants, and these studies looked at hyperbaric oxygen therapy compared to a sham, where the outcome was cognition. And the findings were that 2 months of this hyperbaric oxygen therapy, so they had 40 sessions, 5 per week within a 2-month period. They found that compared to sham, this improved global cognitive scores, attention and executive function. There's 2 studies that looked at smell disturbances, which we know were common with long COVID. So the first one of only 30 participants looked at intranasal platelet-rich plasma injections. So they got 3 injections separated by 2 weeks and compared this to saline. They found that this improved the participants' olfaction, I don't know if I said that right, with their sniffing sticks TDI at 3 months. Then the other study looked at olfactory training 3 times a day for 90 days, combined with this supplement compared to the supplement alone, and this was a negative study. So really overall not much evidence on how to improve neurological traits for people with long COVID, and then our next speaker, Bruce, will go into this more. For the chest traits, again, not much evidence. So there's 1 study with only 8 participants looked at the effects of a beta blocker on lung function, and they reported the results in a way that there was no actual clear between group comparisons. This study that was larger and 60 participants looked at endurance training following pulmonary rehab guidelines. So participants received exercise training twice a week for 10 weeks and compared this to standard physio care. At 3 months, the people who received the exercise training according to the pulmonary rehab guidelines did improve their breathlessness, and this was assessed with the multidimensional dyspnea profile A1 score, which is commonly used in respiratory medicine. 2 other studies, which I'll mention in a few slides' time, looked at chest traits as secondary outcomes. So they looked at respiratory muscle training, and the respiratory muscle training compared to a sham did improve respiratory muscle strength and breathlessness as well. Fatigue, which is the most common long COVID treatable trait and often reported as the most impactful on people's daily lives. There's only 2 studies that we found that looked at fatigue as a treatable trait. So this first one on the left looked at aromatherapy. So the intervention group inhaled essential oils for 15 minutes twice per day, and they were compared to the inhalation of inert odorless oils. And so this study reported that there were improvements in fatigue with the intervention group. And then the study on the right, which is a larger study, looked at high definition transcranial direct current stimulation. And this is a therapy that has been used in other conditions like people with MS, for example, who experience fatigue. And they compared this to sham. And both groups received low intensity exercise while they had this therapy, and both groups also had education. So the difference was really whether they had that high definition transcranial stimulation compared to the sham. And they reported that the intervention group did experience a reduction in fatigue. Lastly, in the treatable trait cluster that has the most evidence, we had 2 studies that looked at cycle exercise test and VO2 peak as their outcome. So these are therapies that are more typically seen in populations like people with COPD or asthma. And these studies looked at, the first one looked at home-based inspiratory muscle training compared to usual care. And the inspiratory muscle training significantly improved VO2 peak or exercise capacity and quality of life. And this is comparable to evidence in other respiratory disease populations. And then this other study looked at 8 weeks of exercise training combined with inspiratory muscle training versus exercise alone versus exercise advice, and didn't find any improvements. This study here looked at exercise training, so 8 weeks of exercise training 3 times a week. And that's very similar to the intensity that would be delivered in pulmonary rehab, and compared the exercise training to exercise advice and found improvements in exercise capacity or VO2 peak for the intervention group. And then this last study looked at supplementation, so twice daily oral supplementation with L-arginine, which is an amino acid, and vitamin C for 28 days versus placebo, and did report benefits in the intervention group for improved 6-minute walk test distance. The last 2 studies both looked at health-related quality of life, and these are the studies that I mentioned before that also looked at the chest traits. So this first study did inspiratory muscle training versus usual care and improved health-related quality of life. And then the other study looked at 8 weeks of inspiratory muscle training versus respiratory muscle training, which had the resistance in inspiration and expiration versus a sham. And they found that the respiratory muscle training improved quality of life. So importantly in this long COVID population is interventions. We don't know how safe interventions are for people with long COVID. So it's important to look at the adverse events of these interventions. Most studies did report adverse events, or they reported on adverse events, and these 5 intervention types were associated with some adverse events. So you can see that the hyperbaric oxygen therapy had 13 adverse events, but they said that this was comparable also to the control or sham condition. The injections had short-term effects relating to ejection site, which is unsurprising. Someone in the aromatherapy group, which was delivered for fatigue, had headaches and withdrew. The therapy that I mentioned just on the previous slides had some skin redness, and then 1 person from the inspiratory muscle training had symptom exacerbation. So really in summary, from this paper, we found that long COVID is complex. So it's not surprising that a treatable traits model of care would suit a long COVID population. And we identified symptoms or complications in 8 different treatable trait clusters. So again, these were the long COVID treatable traits in the different clusters. And there actually is similarity with a core outcome set that was published for long COVID. And so this core outcome set and our treatable trait clusters, it doesn't represent all traits that someone with long COVID might have. But what it does do is sets a starting point or a minimum set of traits that should be assessed in both research and clinical practice to help start the treatable traits model of care, or help start, finding a personalised intervention for someone who has long COVID. We also found that more evidence is probably needed on long COVID treatable traits in different subpopulations. So there really wasn't much looking at how people differ if they were hospitalised or not hospitalised for their long COVID, or if they were vaccinated versus not vaccinated for their long COVID. So we don't know whether, the most prevalent treatable traits change according to these different things or other factors. We still know very little about how to prevent long COVID. And in these studies, in those 4 studies that looked at long COVID prevention, there was really no clear way of defining what constitutes long COVID as an outcome. So we need more consensus about how long COVID is defined and can be used as a clinical trial endpoint. So some of the studies, or one of them, had a doctor diagnosis of long COVID, and then others said, they had symptom questionnaires or health-related quality of life questionnaires, and if they scored a certain way on those questionnaires, they were deemed to have long COVID. So we really need to better define what constitutes long COVID as a clinical trial endpoint. There's some evidence that exercise training or respiratory muscle training may help some people who have long COVID, and really only those people, the evidence is only available for those people who have specific chest and functional limitation treatable traits. And so, as Peter mentioned, I did work on these guidelines for exercise across the clinical course of COVID. So this is from acute to long COVID. And it's important to emphasize that if exercise is used as a therapy for people with long COVID, that there are different contraindications, including ongoing fatigue for that therapy. So exercise doesn't suit everyone, but it may be suitable for some people who have specific treatable traits. And then lastly, and importantly, we really do need more high quality randomized controlled trials to look at different therapies for the management of long COVID. And really there was little to no evidence of therapies that target fatigue or psychological or pain or sleep treatable traits. Thank you.
Thanks, Hayley. That was a great overview and took us through the complexity of long COVID and the 8 key clusters that came out of the systematic review. And you'll notice that one of the key clusters was neurological symptoms. And we're fortunate to have Professor Bruce Brew address this topic specifically. So looking at neurological treatable traits for long COVID. So Bruce is a professor of medicine at the University of New South Wales and the University of Notre Dame. He's the director of the Peter Duncan Neurosciences Unit and the St Vincent Centre for Applied Medical Research, and a neurologist at St Vincent's Hospital in Sydney. He's got a long-standing interest in HIV neuropathogenesis, particularly in relation to cognitive impairment at both clinical and basic science levels. And he's going to bring this long-standing interest to the topic of neurological treatable traits for long COVID. Thanks, Bruce, and over to you.
Thanks very much. I'll just share my screen. Right. Can you see that okay? Good.
Yes.
Yep.
Yep. Okay, thanks very much for asking me to present. And just by way of overview, I'll talk about just briefly what we found through Hayley's hard work, what updates have changed potentially our findings, and what future studies should do, most particularly in relation to biomarkers and pathogenesis, and improvements in design of studies. So just to briefly recap what we found, as Hayley mentioned, the neurological cluster just pipped the post and beat chest. So it's a very common cluster and is clearly very significant. What do we mean by the neurological cluster? So it's really the brain fog / cognitive impairment is the most dominant part of this cluster, including headache, less commonly smell, at least with long COVID, now with the more latter variants that we've been subjected to, same with taste. Impairment of balance, not so much. As Hayley mentioned, the characteristics of the RCTs that explored intervention for the neurological traits were frankly disappointing in their efficacy. So the only one that showed some benefit was the hyperbaric oxygen therapy, which is well designed, but clearly not something that can be scalable. 4 RCTs did include neurological symptoms as secondary outcomes, such as cognition, smell, taste, and there was no benefit. Importantly, there were no interventions targeting psychological treatable traits, so as a primary outcome. 7 RCTs had psychological symptoms as secondary outcomes. In relation to depression, hyperbaric oxygen therapy and exercise training did seem to be helpful. In relation to anxiety, high definition transcranial direct current stimulation also seemed helpful. These were secondary outcomes, however. So as Haley's mentioned, the treatable trait in long COVID neurological cluster really focuses on cognitive impairment, headache, smell, taste dysfunction, and loss of balance. We can use the various trait identification markers in relation to cognitive impairment. The most commonly used one is the MOCA. That's quite a useful test as long as it's done properly. And there are educational sessions online that people can do to make sure they're performing the test in the way that it should be performed. The same with the mini mental state exam score. These are also available in other languages, and they are also available in abbreviated forms for telephone interviews. So they're helpful as TIMs or trait identification markers, but recognize, of course, that they are relatively blunt instruments as markers go. Now, what updates have changed our findings potentially? I can tell you in short, no updates thus far have changed our findings in a broad sense. In a more detailed sense, there are 2 studies that I think are worth mentioning. One is published and one is under review and hopefully will be published soon. They actually detail the type of neurological complaints. And this is the Beretta et al. Study in neurology, which goes into the acute COVID manifestations as well as the long COVID manifestations, particularly in relation to, for example, acute encephalopathy, ischemic stroke in the acute phase, and then in the later phase, cognitive impairment, headache, and so forth. So I think it is a nice summary. It gives a good approximation of relative number of cases for each of these clusters, both in the acute and in the long COVID phase. It's from Italy, so there may be differences according to other countries, but I think the general theme of this granular detail of the neurological complications is likely applicable across the board. Another good study that should be published fairly soon is that from Canada. And the advantage, this is the Masters et al. Study, the advantage of this study is that the Canadian system, by virtue of its universal healthcare and electronic medical records, enabled the researchers to really get a very detailed handle on the type of neurological complications and when they occurred. And those data, I think, are really quite reliable because of the nature of the universal healthcare system and because of the electronic records that enabled accurate data collection. So you can see that odd conditions, rare conditions like myasthenia do seem to occur somewhat more commonly. They do cross the line, but perhaps somewhat more commonly. Coma, brain fog clearly are important. What future studies should do, I think my take on the future direction is really focused on a better understanding of pathogenesis. And probably it's better to say pathogeneses. Now, equally clearly, it's a bit of a hodgepodge at the present time. That's not to say, however, that we can get glimpses of what is a likely pathogenesis in a particular treatable trait and use that to then progress to a marker that can be utilized in the study. So this is an adapted figure from Neuron back in 2022. And you can see people have questioned whether autoimmunity may be playing a role in long COVID, particularly in relation to neurological complications. Neuroinvasive infection. I think this is a controversial area, but the majority of studies have shown that you do not have brain infection. Like anything, there will be occasional exceptions, but the majority do not have evidence of brain virus replicating. There may be viral fragments in some patients. These may be in exosomes. Whether they are triggering an immune response, I think, is tantalizing, but not definitively proven. Then there's the concept that there may well be some sort of reactivation of latent viruses like Epstein-Barr virus. Again, tantalizing, but not proven. Then there is also the concept of these microclots that people have talked about and how they might be disrupting the blood-brain barrier and causing cognitive impairment and perhaps some other neurological abnormalities. They may also be causing thrombotic or tiny thromboses throughout the cerebrovasculature. I think personally that's less likely given our own studies and those that have been published, which have not shown micro infarcts in the brains of patients with long COVID. Now, that doesn't mean that they can't exist and that they may be present beyond the resolution of the scanning device, because most scanners are using a 3-Tesla machine. But I think I would place less emphasis on the concept of microclots, at least from a brain perspective, and more emphasis on the blood-brain barrier disruption, for which there is some evidence. Then the issue of hypoxia more generally and metabolic disturbances, I think, is a very interesting concept that may lead us to a metabolic, a treatable trait marker, and most particularly a disturbed gut microbiome, for which, again, there is some evidence. And then, last thing, there may be deficits in this particular pathway called the kynurenine pathway, which overlaps with resolution biology. And at a very general sense, you could say long COVID is some sort of defect in the ability to resolve whatever the insult in precise terms is. Now, that may be because there's an ongoing stimulus, or the other side of the equation is that the stimulus is no longer there, or it's there to a minimal extent, but the response is not right, and the off switch to then become a resolving issue is not working. I'll go into that in a bit more detail. And then there is a recent publication in Cell from Wong et al. Looking at tryptophan serotonin metabolism. This dovetails somewhat nicely with our own data, but looking at it from a different angle. They have found, both in humans and in animal models, that it would seem that long COVID is associated with intestinal malabsorption of tryptophan, and that leads to a degree of serotonin deficiency, which then causes a whole cascade of effects, some of which then affect the brain, either directly or more commonly indirectly through perhaps hypercoagulation related to platelet dysfunction through serotonin deficiency, and perhaps through vagus abnormalities as a consequence of serotonin deficiency. So that is very attractive in the sense that there may be a TIM, a trait-inducible marker, namely serotonin, or tryptophan perhaps, that could be measured in the blood, and that then would lead to potential treatments. And I can tell you already that people are considering and using serotonin reuptake inhibitors to boost serotonin levels. This needs to be subjected to a proper RCT to really get a handle on whether that strategy is going to work. But at least these data would say it's potentially promising. Now, I think this ushers in a really important concept, and that is you must choose your trait-inducible marker extremely carefully and make sure that it doesn't just cross-sectionally correlate with disease, but it longitudinally correlates with what you're focusing on, what traits you're focusing on. And I use our publication from last year just to highlight this, where we looked at a number of different tryptophan degradation pathway or kynurenine pathway markers and their relationship to cognition. And you can see that there, in the 6 panels, you can get different results according to how, at what time point after the diagnosis of acute COVID, you do your analysis of the particular marker. Having said all that, the only marker that we found was this end product of the pathway, quinolinic acid, which can't be measured so easily, but which can be measured in a surrogate way by the kynurenine tryptophan ratio. So what does all this mean for the future? Well, I think design issues should, as Hani mentioned, identify variants. At the moment, it's sort of by implication as to when the study was done, but that's not going to work, I think, in the future, given that variants seem to be coming and going quite frequently. Second, the vaccination status unequivocally needs to be recorded in whatever study you're doing, be it descriptive or interventional. And it's not just vaccination status, but how many and when in relation to your study time point. Third, there's no doubt, I think, that hospitalized and non-hospitalized patients should be separately studied. And that's because the hospitalized patients are usually sicker, but more importantly, they are at risk of these other complications, such as in the context of neurological disease, strokes, for example. The next issue is that the cognitive assessments, if you're doing some sort of descriptive study or an intervention study, should, where possible, use better instruments. Now, the attraction of a lot of studies is that there are huge numbers and that they've used simple instruments to get those huge numbers, those instruments being the MOCA. There are some other instruments that can be used to assess cognition that, yes, are a bit longer in their requirements for administration, but nonetheless would be more accurate. Where those can be performed, I think it would be to the advantage of the particular study. I think we've gone beyond large-scale studies to map out the treatment clusters, the long COVID clusters. Now we should be drilling down into smaller studies that have much better instruments to really get at a handle what's going on and how to best help the patient. And then, as mentioned, the time since acute COVID should be identified. No study matched intervention and control groups. And the difference between intervention and control groups for the mean time since acute COVID was greater than 60 days in our study that Andy led. Why is this critical? Well, long COVID is a dynamic illness. If you were to come into this field de novo now, you would have and you looked at all the studies and what's been published, past reports, etc., you would have the concept that long COVID is some sort of unitary disease, but that's a fatal flaw. It's not. Even within the clusters, there is dynamism. So I really think it's critical that we have future studies that accurately, where possible, record the time since acute COVID. Why is it in particular so important? Well, the effect of a descriptive study or some intervention will likely be very much influenced as to when, in relation to the acute COVID illness, you actually intervene. And this is nicely studied, nicely shown here in this relationship between quinolinic acid, the tryptophan end product, which goes up, peaking around 6 months, and then goes right down at 12 to 14 months. If you intervene early on, at say month 2, month 4, you may well be able to reverse the deficits. But if you're intervening later on, at a year plus, I'm not sure the extent to which some of those deficits may be reversible, some may not. Hopefully they're reversible, but I wonder if the degree of reversibility may be compromised. And so you can see that you need a marker that adequately reflects that, not just the time point, because equally, you can see at month 12, there are some patients who still have elevation of this inflammatory neurotoxin, and they may well be benefiting from some therapeutic intervention. So you cannot go just with the time since acute COVID, but it's a good starting point upon which you will hopefully be able to base an appropriate TIM or treatable, trade-inducible marker. Thank you.
All right. So thanks for the opportunity to talk to you today about the long COVID clinical practice and real world management. My name's Anthony Byrne. I'm a respiratory physician at St Vincent's, and I run the long COVID clinic at St Vincent's along with Professor Stephen Foe. So I wanted to acknowledge all the people that have worked in the clinic. We've been going for 2 years now, and the long COVID clinic, and obviously want to acknowledge all the work of Hayley and Bruce and Peter on this review specifically. So, you know, I just have 20 minutes, I think, to just talk about the real world application of this treatable traits approach. I wanted to just step back and say, you know, how big this problem is. You know, I think, you know, it's 750 million people. It's probably a lot more than that, as we know, that have actually had the virus in the last 3 or 4 years, you know, just approaching 7 million official deaths. But I suspect that's a significant underestimate of the number of people that have died from the virus, which is the most deadly single infection in the last 3 years. The St Vincent's Hospital long COVID service, we accept patients over the age of 16 that have persistent symptoms, essentially the long COVID definition that Hayley mentioned before from the World Health Organization. And they're GP referred patients, and they have some baseline assessments. And one of the things that Bruce just mentioned was about the dynamism of the treatable traits and the clusters, and that's very much what we see in the real world when we're trying to triage the patients, and that's the job of our CNC Ellie Asghari, who does an amazing job with that, and she tries to sort of see if they're more a rehabilitation neurological type cluster or more of a chest sleep type cluster. And sometimes what we find is that someone that's like that at 3 or 4 months might not be like that at 6 or 7 months. So it can change over time. And I think we do understand, as Bruce was delving into the pathobiology of what we know about long COVID, that it's very much a immune dysregulation illness. And you can see that the symptoms do improve over time, but what we understand now is that, the year or two after the initial infection, it's all very slow compared to the first 28 days when most people will recover within that acute period, which is 28 days post infection. I just sort of point to the Australian Lung Foundation and some resources that I think, some people would find useful that we're involved in developing for patient understanding, which I think is, both patient and clinician understanding of a new illness is really important. So I direct people to that to have a look at. So I won't go into this because it's been defined, and the complexity is becoming more understood, but it's certainly a multi-system condition. So specifically to the respiratory sequelae and what we see in the clinic and in clinical practice, we see a number of consequences of the virus. This is a SARS virus that latches on to ACE2 receptors. There's viral replication and there's alveolar injury that occurs in those with a severe initial phenotype, the ones that end up in hospital. And that's, as Bruce was saying, there's a difference between those that are hospitalized, largely due to pneumonitis, but not always. Sometimes they get cardiac arrhythmias, chest pain, or other reasons for coming into hospital. And we do see a difference in the sequelae now compared to 2 years ago, when there was certainly a lot more patients with hospitalization and pneumonitis and ending up with alveolar injury and diffuse alveolar damage, or DAD, that was seen on histopathology of patients that have died from COVID. We certainly do see thrombosis in the acute period, and we also see in the subacute and chronic, long COVID, airway injury. We see this pro-inflammatory state that affects the respiratory tract. So I think those sort of mechanisms are important to understand in treating this condition. In terms of management and prevention, and Hayley touched on this as well, and mentioned one of these studies, I think the metformin study. But the first step, I think, which is sometimes missed, in fact, maybe often missed, is that you've got to have a diagnosis. And if you don't have a diagnosis, then you won't actually get any opportunity to have antivirals or any chance to mitigate. So doing a test, a rapid antigen test, we know there's a sensitivity potential issue with rats, and so PCR, if someone's symptomatic and negative, is a reasonable thing to do at the get-go in the real world. In terms of mitigation, antiviral therapy, there is some evidence, from the veteran study from the States, looking at antivirals in those people that were eligible for them, and showing a reduction in long COVID of 26%, compared to those that didn't. And then in terms of in the acute phase, as Hayley was mentioning, with those interventions, there is some evidence in a randomized controlled way for metformin for a period of 14 days, reducing to 6.3% at day 300 compared to 10.4% the incidence of long COVID. So just moving on to treatable traits, which is the topic of this talk, of course, and what are the treatable traits? I mean, I would sort of break it down into this, from a clinician, physician treating these patients and investigating them, and this is sort of the things that I would look at, So there's conditions that we know of in medicine, and we know that these long COVID patients experience these conditions, I think, at an increased rate. And so that helps us to treat their symptoms and their conditions. So we see asthma and COPD, we see infectious inflammatory bronchitis and pneumonia, and we see PE in terms of respiratory treatable traits. And then within cardiac, we see arrhythmias and postural orthostatic tachycardia, which has been seen in other post-infective, post-viral conditions. Myocarditis and pericarditis have been talked about a lot, but much more common with the virus compared to vaccine, and last longer. Ischemia and cardiac failure. Sleep, I think, is really important, for those of us that treat sleep disorders. Haley mentioned it, and when you put into that, panic disorder, post-traumatic stress, anxiety and depression of having a new chronic health condition, it's not surprisingly something that can affect sleep and sleep hygiene, and it needs to be assessed. Sleep conditions that presumably predate COVID, of course, like obstructive sleep apnea, but maybe undiagnosed, and periodic limb movement syndrome and other conditions. Bruce touched on autoimmune conditions, and certainly we see, and talking to my rheumatology colleagues, they're patients that have these rheumatological disorders that then get COVID. They're just very much overrepresented in those patients that go on to develop a long COVID condition. So it's a little bit of a chicken and the egg, I think, with that, but there's certainly an increased risk of long COVID in that population. And then neuropathic type pain, we see a lot of that. We see a lot of pain as an issue that sort of requires some thought and some treatment. So in terms of what we find for respiratory specifically and treatable traits and some conditions, we often see when we measure lung function in these patients that it's normal. And that's reassuring, of course, when we find normal lung function, but it also causes confusion in many people when there's breathlessness but normal lung function, or breathlessness and no hypoxia. It still amazes me the focus on oxygen saturation and that the oxygen saturation is normal, therefore your respiratory system is normal, which is not the right conclusion, of course. So we see sort of some people that have organizing pneumonia, a significant number that have post-viral increased risk of bacterial and fungal infections, although there's a paucity of data on that, and a lot of it is coming from a couple of years ago and from the acute rather than the post-acute state. Same with venous thromboembolic disease as well. But certainly in the clinic, we see reactive airways disease overrepresented, and I'll present some data on that. Respiratory muscle dysfunction, I think, is also very common in this population. So breathlessness, my approach to breathlessness as a treatable trait and how to investigate it in the real world would be to break it down into life-threatening, important, and then sort of annoying and disabling causes. So for life-threatening conditions, pulmonary embolism is up there, and we investigate that in different ways. Of course, CT pulmonary angiograms commonly used, but VQ lung scanning, my feeling is that it's a more sensitive test for subsegmental pulmonary emboli. And obviously pneumonia and organizing pneumonia are both quite important conditions. Arrhythmias and myocardial ischemias, they're overrepresented in a post-COVID population, and there's lots of shared risk factors for severe disease and long COVID. So they're important to investigate. And these sorts of symptoms are often result in healthcare utilization and emergency presentations. But for important conditions, asthma, pleural effusion, and cardiac failure, and Peter will know very well that the diagnosis of asthma can be quite challenging. It's not always, it's often not straightforward. And then in terms of chronic and annoying symptoms, chronic hyperventilation, panic disorder and anxiety, very much diagnosis of exclusion, and only after doing many other things. And of course, there's overlap with these conditions, and people can have anxiety and panic, but also have asthma. So that's, I think, important to understand as well. Chest pain, once again, we've got similar life-threatening conditions and then important conditions and annoying and disabling symptoms. And for a lot of these patients, that they've had many of these investigations that exclude the life-threatening. And sometimes what happens is it's, okay, well, that's fine, you're okay. But they very clearly are not okay, and they're still suffering from these terrible symptoms. And then so in a month or two's time, when they have that severe chest pain, do they go back to the emergency department, or what's the strategy? So it's really important, I think, to both investigate and then have some education on how to manage these conditions. Coughing, lots of reasons for cough. The respiratory physician will have 100 different causes of a cough, but once again, we can break it down into life-threatening, important, and annoying and disabling. And it involves doing some investigations, providing some education, having reassessments. It all can't be done in one consultation of 15 minutes. It very much takes time. It takes multiple consultations, hopefully not complications. So just to give you an example, maybe a real world example of a patient that's not an uncommon patient that we see both in the long COVID clinic, but also referred in private practice. So this is an example of a 48-year-old female school teacher. She tested positive on PCR testing in January of 2022, so 2 years ago. She'd had 3 prior vaccinations, like many people 2 years ago at that time. And she was referred to me from her GP, who was really struggling with the severity and complexity of these symptoms at 4 months post initial infection. So her initial infection did result in a hospital presentation, but not admission. So she had chest pain. And so like a lot of people with chest pain, it's pretty concerning. And so she went to emergency, and she was not hypoxic. They did some investigations, including some blood tests, troponins and ECGs, and they were okay. And so she wasn't admitted. And at that time, there was no antivirals that were readily available, so she didn't get antivirals. She had symptoms which were pretty typical of an acute viral illness with COVID, rhinorrhea. She did have loss of smell and taste, and she had myalgia. She had cough, chest pain, breathlessness, and lethargy. Now, the number of symptoms is important. Because the more symptoms you have, with a magic number being 5, the longer it takes for them to go away, and the higher the risk of long COVID. So already at this point, you could predict that female 48 with lots of symptoms and an ED presentation is at high risk of developing long COVID. Her chest pain was initially managed with anti-inflammatories with sort of minimal success, and she had slow resolution of the symptoms of taste and smell loss. So when I saw her, she was really fatigued. She was debilitated. She had this cognitive dysfunction that Bruce was talking about. She certainly had lethargy. And not only did she have lethargy and tiredness, but she had hypersomnolence. So she was excessively sleepy. And I think there is a distinction, and tiredness and being sleepy don't necessarily always go together. So I think it's important to tease that out with questions. So she was sleeping 12 hours, from 7 till 7. She had a lot of pain, a lot of anxiety, a delayed sleep phase, and she was unable to work as a school teacher, at least not full time. She was struggling to work 2 days a week, having previously been fit and well, no conditions, used to run regularly, and on no medications. And this is a pretty common story. Stop being was 4 out of 8. So would suggest there's a high risk of sleep apnea, and she was pretty hypersomnolent, moderately so. Okay, so what do you do about it? Well, in terms of initial investigation, I had a look in her nose and back of the throat with nasoendoscopy. She had quite a lot of candida on the base of her tongue. She had some mild turbinate hypertrophy, I thought. We did some blood tests. We did a CT and a sleep study. And in terms of initial management, I put her on amphotericin for the candidiasis, just some lozenges. And because of the anxiety and delayed sleep phase and pain, I started her on 10 milligrams of amitriptyline for that. She came back a couple of months later with her niece because like a lot of patients, she forgot a lot of the consultation, didn't remember much of it. So important to write it down, and it's good to have another person there to hear practically, because these patients forget. Memory loss is one of the symptoms that's common. So she'd had some improvement with sleep and mood. She was taking the amitriptyline half the time. We'd done a sleep study which didn't show sleep apnea. She actually had quite good objective sleep, sleeping for 6 hours, no restless legs. She had pretty good sleep efficiency. But despite that, she was really tired and still very sleepy, with the Epworth still pretty high. So what did we do for her at that time? Well, look, I elected to increase the amitriptyline to 20, and I asked her to take that more regularly. I, for her hypersomnolence, prescribed her armodafinil. She was really debilitated. That was on a private script. And, she was also seen in the long COVID clinic. And so she was lucky enough to be reviewed by the psychologist, the physiotherapist, and also rehabilitation physician, getting back to work, return to work plan. She's now nearly a year down the track, still not working full time. So that's a big deal. She had reduction to her sleepiness with the armodafinil. And she still was complaining of pain despite that, and she had headaches and memory impairment. So she actually was reviewed by, it was actually Bruce. You may remember this patient, Bruce. And Bruce sort of did some investigations, which included an MRI of her brain, I think, and she was started on Ajovy for her migraines, and she had an improvement over some time with all of that intervention. She was sleeping better, but she still has impaired memory at 18 months. Her cholesterol was found to be high, and so, based on that, and cerebrovascular risk, and maybe some theoretical ideas about atorvastatin, she was put on atorvastatin. She was considered for the randomized study that was called the Stronger trial, which was randomizing people to 40 milligrams of atorvastatin or not. So this was done outside of that study, but she did consider being enrolled in that study. That's finished recruitment now. And then I've just seen her at 2 years, and she's much better, like a lot of patients at 2 years post-infection, but she is not back to baseline. She is working 4 days a week rather than 5. She did have a try of going on duloxetine rather than amitriptyline, but found that her pain symptoms flared on that, and so she went back to amitriptyline. She's still on armodafinil, and she takes that on a private script. So she's taking that basically on school days. And it does help her a lot, but she still sort of fatigues by after lunch, sort of around 2 o'clock. She's still feeling quite tired and sleepy. So that's sort of one example. But it's not an uncommon sort of scenario of symptoms and an approach to treating what makes sense clinically to treat. I'll just talk, maybe if I can, just for a couple of minutes about oscillometry, the forced oscillometry technique, which we've been using in the clinic as another lung function test to complement spirometry, and just some initial data that I presented last year at ERS, looking at some long COVID patients that we've seen, and showing sort of the demographics that we see. So, median age of 47, body mass index just over 30, mostly vaccinated 2 to 3 times, some smoking history, but not a lot of smoking history. Diabetes, a little bit more common in a female population, but not significant, and lots of symptoms in terms of, they all get the Yorkshire 19 questionnaire. So very symptomatic population. A little bit more chest pain in the female population, which was interesting. We found that 60% of the patients we saw were females with a mean age of 47, mostly non-smokers, mostly not admitted to hospital, 90%. Chest pain, shortness of breath, and fatigue of moderate severity, as we've heard, really common. We found spirometry was abnormal in 25% of patients, but oscillometry was abnormal in almost half of the patients. So it sort of has a higher pickup rate of finding an abnormality. And then on this graph, which hopefully you can see mostly, you can see that in the first and second consultations that there is an improvement over time with both spirometry and oscillometry, and that corresponds to an improvement in symptoms, but oscillometry remains more commonly abnormal. So by way of follow-up in our clinic patients, there were mostly respiratory symptoms in those, not surprisingly, triaged to the respiratory arm of the clinic. And of those, 40% had symptoms with abnormal oscillometry. When we say symptoms, we're saying, respiratory shortness of breath type symptoms. And so there are these patients that do have normal oscillometry, but they also have symptoms. In terms of the abnormalities, the common abnormalities that we found, we found most commonly that the resistance between 5 and 20 hertz was the most common abnormality. 26% of patients had that abnormality, sort of corresponding to probably abnormalities of the small airways. So our conclusions just from this initial data was that we found oscillometry to be a useful test in finding abnormalities in 50% of long COVID patients, and it was more frequently able to detect abnormalities in this population than spirometry, and it was also more frequently seen as an abnormal finding in the second visit. So that's my talk, and I think maybe now we're at the point where we can ask questions to everyone.
We have some sound issues in the room. So instead of using the podium, I'm going to try and chair the Q&A from Vanessa Clark's computer. Can I just check, can people hear me? Thanks, Bruce. And can you hear? Great. Okay, fantastic. And I've got Hayley Luthwaite sitting next to me. Well, that's just to prove. So I think we've had 3 really interesting and different presentations. Hayley took us through the symptom clusters and the interventions and highlighted that neurological symptoms and chest symptoms were really dominant. And then Bruce delved deep into neurological treatable traits, sort of describing what their characteristics are and potential mechanisms. And then we heard from Anthony about how you apply this in clinical practice, in particular with a respiratory flavour. So I invite people either in the audience or speakers to offer questions. And the first questions are from Kirsty Porteous saying, can we please show the slide that preceded the respiratory sequela and the second last slide about small airway resistance again? So I guess you're going to have to show your screen again, Anthony, unless Vanessa, you have the slides on here.
Yeah.
No. Yeah.
Okay. Is it that one that you're talking about?
So that was the second last slide about small airway resistance.
Yeah.
So do you want to, Kirsty, did you have a particular question about that? I wonder, whilst she's asking, Anthony, how does this relate to what's known about mechanisms of COVID infection? For example, are the small airways a particular focus
Yeah, I mean, for me, and one thing that we would like to do in the data that we have from the clinic is look at, and one of the questions that I was asked at ERS when I presented this was how was it treated? I mean, I think what we have done is look at those symptoms that would fit with bronchial hyperresponsiveness and small airway dysfunction and essentially a post-viral asthma. And so these patients that we give them pre and post bronchodilator and we see some changes in their small airways on oscillometry, then our approach would be in the clinic to give them treatment for asthma. And then we would assess their response to that. And a lot of these patients, they might have had childhood asthma, and then they've sort of forgotten about it, and then they've had COVID. And then, for me, that's sort of what we see in other viruses is that we see that the respiratory viruses, this particular respiratory virus causes inflammation, which is ongoing within the small airways. And that results in symptoms of cough and breathlessness. We can measure these abnormalities, and then we look at the response to treatment for treatment.
So you're saying about 2/3 might end up getting asthma treatment based on abnormal FOT and symptoms?
Yeah, this is a pretty selected population, but
Sure.
in those that are, I mean, these patients have, typically they're sort of 6 months post-infection.
Yep.
They've seen a lot of GPs and other doctors, and then they're coming to us still pretty debilitated. So, yeah, in that select population with respiratory predominant clusters, with these measurable abnormalities, I think that would.
So if you could go to the slide that preceded the respiratory sequelae slide. So if you can work that out, you go to the top of the class. And whilst that's happening, I don't know if you can do two things at once. Do you find any complications doing spirometry in this population? And what I'm thinking about is the breathlessness, the fatigue and the chest pain, and spirometry might be considered challenging in those conditions.
Yeah, exactly. I mean, one of the things when we looked at this data was that the number of completed adequate quality tests for spirometry was less by a lot than oscillometry. So one of the other important things here and potential utility of this test is that it's much more user-friendly for everyone, but particularly a long COVID population that's suffering from chest pain, palpitations, all these things. So when they can just do tidal breathing rather than a forced expiratory maneuver of spirometry, the completion rate was almost 100% for oscillometry compared to maybe 70% for spirometry.
Okay, so that seems like a useful takeaway from this is that if forced oscillation technique might be a useful monitoring and investigation tool in patients with long COVID and respiratory symptoms, because it identifies something that can be treated with small airways disease, and it's easier to interpret and better received by patients. So Meredith King is following on with a question. Do you do oscillometry on the patients attending the non-respiratory arm of the long COVID clinic?
It's
and
a good question.
Just wondering, is FOT more likely to be abnormal in people in general post-COVID?
We haven't been. It's something that we'd like to do. It's mainly because of logistical not having the ability to do that on a different day with the availability of the OS with the device because it's on a different day. So we haven't been doing that. But yeah, it would be interesting to see those patients triaged to a non-respiratory clinic because there is overlap. I'm sure there will be overlap, but the predominant cluster is not respiratory by virtue of them being seen in the rehab arm.
Mm-hmm. So I'm now going to, Vanessa McDonald.
Thank you. Can I be heard? Like, can you hear me, Ed or Bruce?
Just, yeah.
Or do you want to repeat it for me?
Yeah, you can come around and ask it.
Okay. So thank you everyone for a great webinar. I've got a couple of questions which I'll try and kind of
be quite brief on, but you both and Hayley presented the data around metformin being effective in terms of prevention of long COVID if it was commenced within a certain period. So just one question there was, is that in only people that were commenced metformin at the time of infection, or if people were using metformin for other reasons, did it have an impact on the prevention of long COVID?
So I'm pretty sure for that clinical trial, it was commenced at the time de novo.
Yeah, it was.
For acute infection. So they were not on it, and they did not have diabetes.
Okay, because the other thing I wanted to ask, which kind of relates to that, is around whether or not there's a metabolic syndrome cluster that potentially we're not recognising in long COVID. And in your case study, you showed the woman who had an increase in her cholesterol, and I think you showed an increase in the diabetes with long COVID as well. And I wonder, in terms of those things that predict long COVID, like diabetes, obesity, yeah, because it certainly predicts worse disease and mortality. Does it predict long COVID as well? And is there a metabolic cluster that we don't necessarily recognise because patients wouldn't say, oh, you know, my blood pressure's high or my cholesterol's high and things like that?
Yeah, I mean, I think there may well be. I mean, you see in the long COVID clinic demographic data that I presented, like the BMI was over 30. You know, so, but you know, is that different to the general population? Maybe it is. Yeah, I think it's certainly something that is worthy of more research, I think. Yeah. So you're sort of saying that maybe these people have an undiagnosed metabolic syndrome and they're getting a benefit. I guess it's still curious that it's only for 2 weeks. I think that intervention was for, so it was just 2 weeks at the time of acute infection for COVID, and yet there was a 300-day sustained benefit. So yeah.
I just caution the use of metformin ad hoc in long COVID outside the acute phase, because you know a reasonable proportion of patients on long COVID develop B12 deficiency, which can complicate the whole issue. So I'd be quite careful.
Yeah, no, my comment was just the same as Ant, in that there is some evidence that people with pre-existing diabetes have increased risk of hospitalisation and more severe disease, so that in itself will increase the risk of long COVID. But then there is some evidence that I've read that people without known pre-diabetes will have metabolic changes consistent with pre-diabetes and diabetes during the acute phase. But that this study, in particular, it was all hospitalised people with acute COVID, and it was
there are other mechanisms, like potential mechanisms, I guess, like metformin's known to act on matrix metalloproteinases. So you know, there may be other pathways where it's acting on as an anti-inflammatory effect, maybe.
Thanks, everyone.
Bruce, I've got a question for you, but others might like to comment. So in the patient that Anthony presented, she had 4 quite disabling symptoms and potentially overlapping. So fatigue, lethargy, brain fog, and excessive daytime sleepiness. I just wonder, what are the clinical ways to sort of sift through a history like that and identify where to go? And if I could be cheeky, I could say that Anthony focused on the excessive sleepiness, but maybe he did that because he's a sleep doctor. But how do we know that was the real issue? And anyway, that's just being mischievous.
Yeah, well, it is difficult in clinical practice. So there's no question that sleep disturbance will impact your cognition and can give you headaches. So how do you tease that apart? And will certainly cause fatigue. I think you have to be really careful in your history. Usually headaches that are related to sleep disturbance occur at the beginning of the day when you wake up, and they get better to an extent as time goes on. But it can be challenging, to say the least. Having said that, you are not infrequently left with the possibility, yes, there may be considerable overlap in causation amongst those 3, 4, and you just treat what you can, to be frank, rather than trying to tease apart what you think is the most likely. Because, at least in my experience, it's a difficult mix with a whole host of intersecting pathologies. So if you go after one, you may have limited benefit. If you go after as many as you can, you're probably going to get a hit that's sustainable.
Yeah.
Hopefully.
And I think that's the challenge, isn't it, Peter and Bruce and others? Like, in terms of doing clinical trials and, having a, research definition, what are the outcomes? Because there's such heterogeneity in these patients, looking at your intervention. So I think they're sort of open questions, but they're really important to answer for the purpose of designing a clinical trial.
Yeah.
Absolutely. So that's where I think you've got to have your TIM really accurately defined as best you can. So in relation to cognition, you need nice sensitive tools for measurement of cognition, and to develop the TIM, a reasonably clean population where their cognition is their major deficit and there's not too much in the way of confounds.
Great. I was interesting to hear your perspective, Bruce, about should you find one problem and treat the problems sequentially, or treat them all together. And that's a common question in treatable traits across the board, which is as yet unresolved. Up here, we tend to go on the bundled treatment approach, but it has yet to be tested to see whether which is the superior approach.
Yeah, look, I think it's really difficult. My personal experience is these patients are often quite sensitive to medication, and so you need to usually go with half the standard dose. And so I've done both approaches. I don't know about you, Anthony, but it really, you have to tailor it to what the patient can tolerate and what they're comfortable with, to be honest. Because a lot of them have had reactions to medications and they're not keen to pursue things.
It's very much personalized medicine, and I think the investigations are useful to exclude important causes. Like with this person that I presented, doing the sleep study and seeing that that's essentially a normal study is really helpful. I mean, because if you had untreated severe sleep disorder breathing or something else, then giving her armodafinil is not the best idea.
So sort of following on from that and recognising that there's more to personalised medicine than drugs, here's a question from an anonymous attendee. Did your patients access other allied health services to get support managing symptoms? For example, counselling, OT support, nutrition, psychoeducation? And thank you for your presentations.
Yeah, thank you. I mean, in terms of the clinic, a psychologist, physiotherapist, nurse, but at the moment we don't have occupational therapy. But I think some of these patients do see through their GP clinics. They do have some supports, dietitians and other supports there in a GP setting. I mean, I think all of it's really important.
Okay, so we have a final question from, we have more than a final question. Gabriel Bennett, have any researchers challenged the outcomes of long COVID to be related to adverse effects from vaccinations? Did it come up in the literature reviews that you did, Hayley?
No, because many of the reviews, for one, didn't look at whether the population in the primary studies were vaccinated or not vaccinated. And then a lot of the evidence was also from pre-vaccination or early vaccination time. So, you know, it might have overlapped between pre-vaccination being available to having one or two vaccinations. So that, yeah, there was no distinction. And that's what Bruce and I said, that, yeah, there's no distinction about that. There is evidence now that vaccination may reduce the risk of developing long COVID. But yeah, I don't know if Ant or Bruce.
I think there's pretty good data on that. I mean, I think, you know, when you look at the studies that were done pre-availability of vaccine, you know, in 2020 and 2021, the ADAPT study that Bruce and I were involved with at St. Vincent's, you know, the patients on that study were not vaccinated because there wasn't any vaccines available. There's good studies from Italy and other places that show the increased rate or incidence of long COVID in an unvaccinated population. So, you know, I think what we're seeing in the population is fortunately a reducing incidence of new long COVID. So I think that's you know, encouraging, but there is still an incidence.
Okay. I think this will be the last question. And so Jenny Oates has asked, is new onset inducible laryngeal obstruction ever a respiratory treatable trait or secondary symptom in people with acute and or long COVID? So when I was on call December, not last December, the one prior to that, a 91-year-old woman presented for the first time with ILO as a sequelae of COVID, acute COVID. So that strain at that point seemed to be giving a lot of upper airway symptoms. So Jenny, the answer is yes. And if you can get VCD at 91, that's just not fair. The last comment goes to Kathy Chapman, who's always entertaining. And she says, I would want my tiredness treated first, Bruce. I nearly read that to be, I would want you to treat my tiredness, Bruce.
Oh, well, I'd love to be able to treat fatigue.
Right.
Fatigue per se is a really difficult
symptom, yes.
Symptom.
Yeah. So thanks to the audience and to the speakers. Three fantastic presentations, a really important topic, and I think new insights that we've all gained from listening to you. So thank you very much, and thanks to the audience.